Okay, thank you everyone for joining us today. Today we have Dr. Florian Gebauer from Wuppertal in Germany. He will be giving us a talk about management of severe type 2 Gastro Esophageal Junction cancer. Thank you, Dr. Gebauer, for always joining us, and the floor is yours.
Right, good evening to Egypt. Thank you very much for the kind invitation. Well, yes, today I would talk about the G-junction type 2 tumors with some rather large controversies, how to operate those kinds of tumors. And I will give you a short overview about the current concepts and, well, the best choice up to date. So I think it's clear for G-junction tumors type 1, the kind of peri or preoperative therapy, either chemoradiation therapy or chemotherapy, followed by a transthoracic esophagectomy is rather clear. Today, the standard is the intrathoracic anastomosis. For type 3 tumors, the extended gastrectomy, either embedded in a perioperative chemotherapy concept for locally advanced tumors, is also the standard. And the problem is, how do we deal with the type 2 tumors? Should we consider those tumors as gastric tumors or as esophageal cancer? And how do we operate them? There are some problems with the diagnosis and the treatment of G-junction type 2 tumors. It starts with the correct endoscopic diagnosis. It's not that easy, especially if you have a larger tumor, to give the correct staging. Either this is a type 2 or type 1 tumor, where's the tumor center and what is the direction of growth within the esophagus. The other point is, how should we stage those tumors, either as esophageal or gastric cancer? And I will show you in a few minutes, there are differences in the staging system that implies differences in the overall survival with the same stage. What kind of neo or perioperative therapy should we apply to those patients? And of course, for us as surgeons, most important point is, how do we operate those patients? And what kind or extent of lymph node dissections should we perform? So today, there is no real hard evidence of any of those questions. Here are the current staging systems for either esophageal or gastric cancer. So if you go into the detail, there are, especially beginning with the stage 3A, there are differences between esophageal and gastric cancer staging. My colleagues in Hamburg performed an analysis, and they staged the same tumor, all of those type 2 tumors, on the left-hand side as esophageal cancer with the current staging system, and the same tumor with the same extent on the right-hand side as gastric cancer. And what you can see, the survival curves change dramatically. So it depends which staging system you apply to the same tumor. And the overall survival is rather different between those two cohorts. Regarding the kind of multimodal therapy, you all know the cross trial that implemented the preoperative chemoradiation therapy in esophageal cancer. It started almost or over 10 years ago, and just recently the 10-year overall survival rates were published. And for the first time, it was shown that chemoradiation therapy preoperatively showed a survival benefit in patients with esophageal cancer. Of note, the main advantage was for the squamous cell carcinomas. The differences for adenocarcinoma were not that big, but it becomes, at least in Europe, standard of care for esophageal cancer. The FLOG4 trial was a German trial that compared the perioperative chemotherapy with the new FLOG regimen compared to the older MAGIC regimen, ECF and ECX. And what the authors could show that there was a increased complete tumor regression rate. It almost doubled from 6 to 16%, and the fraction of patients that did not undergo surgery decreased dramatically from 19% in the old MAGIC regimen to 7%. So FLOG becomes the standard of care for perioperative therapy in gastric cancer, especially in Europe. So the question is now, and the overall survival was a bit better for the FLOG regimen than for the MAGIC regimen. So the question today we are confronted with every day is how should we treat a patient in the multimodal setting? Should we send him to neoadjuvant chemoradiation therapy or chemotherapy? And there are two ongoing trials. Well, they are not really ongoing anymore. The ESOPAC trial is a German multi-center trial. They included GE junction tumors 1 to 3. Primary endpoint is the overall survival, and the recruitment completed last year in February. We are highly expect the results. We expected them on the ASCO this year, but they didn't show any. So we hope end of this year or with the beginning of the next year, we can answer the question whether FLOG or cross is beneficial for patients with esophageal cancer or GE junction tumors. The new AGAS trial completed already also their recruitment, and this comes from Ireland, from John Reynolds. And they compared pretty much the same, the cross regimen against the perioperative chemotherapy. There is a little pitfall in this study. They started a few years ago with the old MAGIC regimen, the ECF and ECX, and changed during the study, during an amendment to the FLOG regimen. So the results were presented almost 2 years ago and we on the ASCO, and we still wait for the full paper to be published. But what they showed there was there's no real difference between the chemoradiation therapy and the perioperative chemotherapy. So in the end, the data we have, there's no real difference. In my former hospital in Cologne, we compared our patients between cross and FLOG. We only included GE junction type 1 tumors here to give a better comparison between the groups, and all were treated with esophagectomy. So the operative arm was the same in both groups. We showed a slight beneficial outcome for the cross patients. There are some limitations. As you can see, the FLOG patients were less. There are 420 patients and 160 in the FLOG group. And the FLOG group had more advanced tumor stages. So this is the problem in the retrospective analysis. How do we choose which kind of therapy do the patients receive? And in Cologne and also in Wuppertal, we prefer the FLOG regimen in those cases with a advanced lymphnodal metastasis staging, and prefer the chemoradiation therapy in those cases with a more localized tumor stage. This is one reason why the cross group could be better in this cohort. So the question is now, what kind of operation should we perform? Either the transthoracic esophagectomy with the intrathoracic anastomosis or the extended gastrectomy. We know that even in type 2 tumors, there are some patients, in almost a little bit more than 10%, that have mediastinal lymph node metastasis above the trachea bifurcation. You cannot dissect those lymph nodes transdiaphragmal, so this is a question whether we should always resect those lymph nodes or not. We know that the frequency of lymph node metastasis increases with the length of the tumor in the esophagus. And you can see in those scatter plot that squamous cell carcinoma, of course, have a higher rate of mediastinal lymph nodes, but also G-junction tumors in the upper mediastinum. So with the standard staging of the CT scan, we cannot be sure that there are no lymph node metastases in the mediastinum, even in G-junction type 2 tumors. In this study from Perry, they had 266 patients and 176 patients with type 2 tumors. What's interesting here, they resected of those 180 patients, almost 100 by transthoracic esophagectomy, 61 patients with transhiatal esophagectomy with a cervical anastomosis, and 21 patients by gastrectomy. Interestingly, only a minority, almost a little bit more than 40% received no neoadjuvant therapy. Half of the patients received chemotherapy alone, and only 11% chemoradiation therapy before surgery. In this study, the esophagectomy group was better than the gastrectomy group for G-junction type 2 tumors. It almost hit the statistical significance, but what you can see is there is a survival difference in my personal opinion. So in this study, the esophagectomy performs better than the gastrectomy. A large database analysis from the US last year included almost 10,000 patients with type 2 tumors. They did several analyses, matched and unmatched. In the unmatched cohort, the esophagectomy group had a higher rate of neo or perioperative therapy. This is interesting because somehow the type of operation is dependent on the type of neoadjuvant therapy, or vice versa. The kind of neoadjuvant therapy was dependent on the type of operation that followed afterwards. So we cannot answer this what was first here, but it's interesting to see that the patients with the gastrectomy received in a lower frequency neoadjuvant therapy. So after the matching, this was comparable between both groups. And what was interesting is that the rate of esophagectomy increased over the years. So as you know, after in these database analysis, the retrospective character, there's always a delay between the reporting of the data and the outcome measures. So the last data was from 2016 here, but the rate of esophagectomy increased and the gastrectomy decreased. And what they revealed in their study, that also the esophagectomy had a better overall survival here in this retrospective database analysis than the gastrectomy. Interestingly, as you can see, the rate of esophagectomy to gastrectomy was 1 to 10 almost. Around 1,000 patients underwent esophagectomy and around 8,600 patients underwent gastrectomy. So at least in the US, the gastrectomy is a more frequent performed type of operation. So to answer these questions, my colleagues in Cologne started a randomized controlled trial that is rolled out in Germany and the Netherlands. And they compared only type 2 tumors and which kind of operation is beneficial for the patient. It's a one-to-one randomization. Only patients with a GE junction type 2 tumor can be included. All patients, when patients have to be treated pre-operatively, they have to receive a chemotherapy. And after randomization, it's either the transthoracic esophagectomy or the extended gastrectomy. There are particular lymph nodes that have to be resected and have to be collected in several locations to compare the extent of lymph node dissection and the extent of the lymph node metastasis afterwards. So how a patient is operated, it depends not only on the preference of the individual surgeon, but also where you live in the world. And there are high differences between Europe, US, Asia, and South America. In general, the higher developed a medical system in the country is, the higher the rate of esophagectomy is. You can summarize this in very easy. I think this is because the transthoracic esophagectomy needs a higher resource level in regards to operative time, ICU capacity, and so on and so on. I think it's more expensive in the end to do a transthoracic operation than a laparotomy and the gastrectomy. You can see it on the right-hand side that the higher the development of the health system in a country is, the higher the rate of the esophagectomy. So, but to be honest, if it's wrong to do a gastrectomy, there's no hard evidence today. There are certain hints that esophagectomy could be better, but we do not know it exactly until we get some randomized controlled studies there. And so long, a standard extended gastrectomy is not wrong to do, especially if you put the comorbidities of the patient into account. If you have lung diseases, heart diseases, and so on, a transthoracic esophagectomy is the more invasive surgery and the more complicated surgery. And you have to put this into context with the perioperative morbidity. So let me conclude today. There are more questions than answers. The esophagectomy and the extended gastrectomy are both feasible operations and options to offer the patient. There's no evidence of the superiority of one or the other technique. And what is, in my opinion, important, the individuals, the surgeons, and the institutional competence should be taken into account. So if you have an department that is very well trained by transthoracic esophagectomy, of course, you can do it more easily and then if you do it 1 or 2 times a year. So in those cases, I would prefer to do the extended gastrectomy because then the transthoracic esophagectomy can be dangerous in some aspects. But of course, both operative techniques must be experienced, must be handled, especially the complication management after an anastomotic leakage. It can be challenging to deal. You need a good endoscopist, and yeah. So I'm at the end. Thank you very much for your kind attention, and I'm happy to answer your questions. Thank you very much.
Thank you, Dr. Gebauer, for this wonderful talk. And please, if any of the audience has any questions, please raise your hand. We start with Dr. Medhat Khafaga.
Thank you very much for this very illustrative talk. I'm wondering how these patients die. They die from distant metastasis or die from local disease?
In the US study, I'm not sure if we have those data in detail. So the problem is always with this retrospective data. After the surgery, the follow-ups become more leaky. So we do not exactly know when the relapse was and where it was. In my personal experience from my time in Cologne, the main problem was distant metastasis, not so much the local recurrence. It happens from time to time, but the distant metastasis, lymph node distant metastasis, and organ metastasis are the main problems.
Thank you.
Okay, any other questions? Please, if you have a question, raise your hand. Any questions from the audience? Okay, Dr. Madhat Khafaga again.
Okay. Yes, another question. Do you think over the last 2 decades, are we improving in the survival of these gastro esophageal junction tumor or not, as regards survival?
Yes, we did, definitely. And there are some very recent data did not show you. You might know that the immunotherapy with PD-L1 blockade after cross pre-treatment and then followed by operation did the recurrence-free survival increased of about 20% again. So there is a real advantage in the last years in the treatment, of course. I'm not sure the impact
is it due
of
to
surgery.
the addition of immunotherapy, or it is why is it improved?
Adjuvant, the Keynote 522 trial, the adjuvant immunotherapy is the game changer in the future for the treatment of esophageal cancer, in my opinion. And it will be implemented in the NCCN guidelines and also in the German guidelines next year, and it will become the standard of care if you have a residual tumor. That is not true for the pathologic complete responders, but if you have residual tumor, then the patient will show benefit of the adjuvant immunotherapy.
Thank you.
So now FLOT is the main treatment?
And also the
main recommended FLOT and immunotherapy?
So in Germany, it's, I would say 50-50 between FLOT and cross. It depends really where the patient is. And
in cross, you give radiotherapy, but in FLOT, no?
FLOT is chemotherapy only.
Okay, why not?
FLOT is 4 cycles before the operations and 4 cycles after the operation.
And so you don't give radiotherapy at all?
When you do a chemotherapy FLOT, then no radiation therapy.
Okay.
Yeah.
Okay, so to conclude, there is no evidence supporting either esophagectomy or extended gastrectomy. Both are equally acceptable, depending on the experience of the hospital to choose which technique.
Yeah,
okay.
Exactly.
Any other questions from the audience? Please, if you have a question, raise your hand. Okay, I think it was a straightforward talk, so not so many questions.
All right.
Okay, thank you, Dr. Florian, for joining us. Always a pleasure to have you with us. And
thank you very much.
Whenever you have the time, we'd always like you to join us.
Thank you very much. See you next
Okay.
time. Bye-bye.
And hopefully
Thank you
see
very
you in
much.
Egypt soon.
Yeah, hopefully, yes. Would be great.
Okay. Okay. See you.
See you next
Bye-bye.
time. Bye-bye.
Good night, everyone. Bye-bye.